Welcome everybody. We start today talking about the nursing process and drug therapy. So we will learn today how we can do nursing diagnosis and how we are going to do through the nursing process when we are talking about some drugs, like any drug, like for example, let's see theophylline, that is bronchodilator, or antihypertensive medication. And we will see that on the next slides. Okay, so let's start. But first, we need to just remember about the QSEN. Okay, QSEN is in all curricula now in the nursing education. Not nursing education only, but it is going to start to be applying in any scenario on the medical field. Quality and safety education for nurse projects, and this is already have quite a while in the around, and there is three things that have been focused this project. Number one is knowledge, skills, and attitudes. All right, so those are the three things that you need to keep in mind all the time, at any time during your practice as a nurse. Okay, so it's what we call the KSA. Okay, so let's continue. And six major initiative of QSEN is, well, we will see that is patient center. So that means our center, our concern is going to be always the patient, which is obvious. Teamwork, collaboration, nursing process. So we need to talk about the nursing process. And monitor the outcomes. Monitor the outcomes means the nurse never stop monitoring during the nursing process. Always are going to start monitoring. Safety, minimize risk and harm to the patient, and informatics. So informatics has the purpose to accelerate, to make it easy, accessible, and diminishing the errors and mistakes. Okay. All right. So let's talk about the nursing process in pharmacology. Okay. So let's talk about general things that we already you already know is the AT-PI, A, assessment, D, diagnosis, AT, then PI, P, planification, I, implementation, and E, evaluation. So assessment. Let's start with assessment. But one thing here I want just to focus here about pharmacology. First of all, assessment, we have, besides the assessment that you already know, the subjective and the objective and the physical exam, you need to find you need to assess the medications, the the medications prior the history, and the medication has taken at that moment. Nursing diagnosis is where you are going to do the prioritization of the uh, diagnosis, nursing diagnosis, and establish priorities. So priorities is the role that we need to prioritize here our implementation and planification. Third point is the planification, that we have the goals and the outcome criteria. Goals and outcome criteria. So what is the goals? For example, if the patient have fever, or the patient have pain, my goal is to decrease the fever, to decrease the pain, and my outcome is going to be, for example, the fever is going to be resolved in about 3 hours or 4 hours, or the pain is going to be resolved in 3-4 hours, or my goal of pain 3 or 5 in the scale of phases is going to reach in 45 minutes or 1 hour, for example. All right, implementation, that is the same to say intervention, intervention, implementation. So this is the stage where you do things. So the doing things is during the implementation. And here is going to be the including the patient education. Then we have the evaluation. So we have 1, 2, 3, 4, 5 steps for the nursing process. Okay, so generally, we have talking about the assessment, and the assessment is the collection of data, objectives, and subjectives. So that means that any, for example, data is telling the patient that you cannot confirm or you cannot measure, that is entered into subjective. So I want to tell you this. So subjective, pain, subjective, right? Everybody knows that. But what I want to remark here is this, that the patient is telling you, I've been taking this medication before, I don't remember the name, or probably she remember the name, and that is something that you can measure, that you can, can you see it? No, right? So that is going to enter into subjective data, subjective data. Okay, so that is about the assessment. We have, besides that, the verbally you are going to obtain the objectives, subjective and objective data. So you do the vital signs, that is objective too. You're going to do after that your physical examination, nursing history, medication history, and in general overall observations on the patient. So let's keep going on assessment and medication assessment. So this is related to pharmacology, baseline. Baseline data is really important. Why? Because the medication, before giving the medication, you have a baseline, vital signs especially, signs and symptoms in general. So if you don't do this after giving the medication, you don't know if the patient is getting better or the same or worse, right? So you need to have some baseline to compare what is the effectiveness of the medication at the end. All right, so for this, for nursing process and make diagnosis based on the drug therapy, you need to remember that always you need to know the medications, right? Pharmacology. Expected therapeutic benefits. So if you have some medication, you need to know what is for this medication, right? So you don't give or give any medication to the patient that you don't know what it is. So expected therapeutic benefit. For example, my patient is hypertensive, I'm going to give antihypertensive. See, I'm not mentioning even names of medication. At this level, this is the second meeting that we have here in pharmacology. So we have antihypertensive, we are going to expect the blood pressure go down, right? So that is expected therapeutic benefit. So why, how, where, when, those are answers that you need to answer yourself, right? So when the medication is going to make effect, how, when is going to be, what are the side effects of the medication, right? Dosage review, so be careful with the dosage. Milligrams, micrograms, nanograms are going to be vital in order to have a successful treatment. Okay, so milligrams to nanograms, you can give 1,000 times less or 1,000 times more. So you need to be super ultra careful when you are doing dosage review. Serum levels obtained, that is when you have the therapeutic range that is very close to the toxic level. Okay, so is the therapeutic index that we saw in previous. Therapeutic index means that if your maximum dose allowed who has a therapeutic range is going to be close to the toxic levels. Okay, so that means if you have, for example, 2.0, that is the maximum level, you can have 2.1, you start to have toxic levels. But that is when you have a therapeutic index very narrow. But when you have therapeutic index that is very high or wider, so that means if your maximum therapeutic range is 2, you can have toxic levels when you have 2.9 or 2.8, for example, to give a number. So it's important to know the therapeutic index. And some medications need to be monitored very closely because this therapeutic index is very narrow. Which ones are very narrow? For example, digoxin is a digital. It's used for heart failure and arrhythmias. Okay, so those are lithium, for example, who is being using for maniac disorders, right? For affective disorders too. So their lithium is very narrow therapeutic index. So that means the maximum dose and the toxic levels are very close. So we need to be careful on that. So that's why we are going to use serum levels obtained. Okay. In cases of patients who has, for example, diabetes or nebulizers, or for example, any other administration medication they need to use, they need to show you that they can they're able to self-administer the medication. Right? So that is a medication assessment. So I don't want to lose perspective here. So you are doing your general nursing process. You start with assessment, all the assessment that you already taught in other courses. In addition to that, you need to have remarks on your medication. So medication assessment, right? So how you're going to do medication assessment? You're going to see that at that time, for example, the patient is feeling this and that, vital signs are that. So baseline data. So you already keep in your mind that you have expected therapeutic benefits. What is going to be, for example, pain or decrease the blood pressure, any doses review. So you need to double check if the doses are correctly indicated with the 6 rights that you have. So the order should be complete. So remember, you need to prevent. If you do it ahead of time, you can recognize there's some mistakes already, if there's some. Serum levels obtained, so depends of the medication, you're alert, open eyes, open ears, alert, red flag. Here you start to probably require some serum levels for the patient. You need to do the side effects. Side effects is very important because when you have side effects are going to be, for example, a low blood pressure if you have hypertension. So you have low blood pressure. You have the heart rate going down too, all right? And they can have other medications. They have toxic levels, for example, toxic levels. Toxic levels of digoxin, for example. Toxic levels of digoxin, you need to be alert on the side effects or what are the signs and symptoms of toxicity of digoxin. Digoxin is for heart failure. And for example, halo. You see the patient start to see halos around. So, and we will see that in another time. Okay, so let's keep going. So we have here nursing diagnosis. What is NANDA, the North American Nursing Diagnosis? So what is this? Is a standardized nursing terminology. So what is the difference between medical and nursing? So I put highlight here nursing because nursing is mostly, forget about the diagnosis of medical diagnosis. So you can work and you can do your interventions, you can do all your planification, your assessment, etc without knowing even the medical diagnosis. So don't rely on that. Don't expect that. Don't look for that. So what you need to do is go to the patient, see the patient face to face, and you will see the patient how he's going to feel, right? So all your assessment, start your assessment there. So from subjective and objective. And the patient is already in the hospital, you come into the shift, and you will see that the patient is feeling in that way. So you review the report or the review from the previous shift, and you can tell what is the response of the patient to the treatment. Okay, the patient is the same, the patient is better, or the patient is getting worse, right? So that is the first impression you have. Okay, so let's keep going. We have some example of NANDA here. One general, for example, is imbalanced nutrition. So imbalanced nutrition could be, for different situations. For example, in this case, related to the gastric ulcer, the patient cannot eat because it's painful, right? Another thing that can be imbalance painful is the patient, for example, elderly people especially, you see they give the food and the patient is not eating. What is the first thing we think? Oh, probably he didn't like the food, or he's depressed, he doesn't want to eat now. But and then you take the food, and then next day the same story, and then imbalance nutrition. What happened? If you ask the patient why he's not eating, okay, probably the patient is going to tell you that he doesn't have his teeth, right? Or he has some problems in the mouth, some ulcers in the mouth. So it's totally a different situation. So that's why you need to just always be alert as do your assessment, okay, including the physical exam at the beginning of your shift. We have an effective clearing airway. So that is related to accumulated secretions as evidenced by physiological behavior. So that means that wheezing, right? So we have wheezing, we have a lot of coughing, right? So we have some adventitious sounds, and that could be, for example, related to medication. All right. So how is this related to medication? Number one, you're taking some ineffective clearing airway. So the patient, for example, have asthma, and the asthma produce a lot of secretion. So 80% of asthmatic patients are having some bacteria growing there. Anyhow, so we have a lot of secretion, a lot of mucus, and the patient is receiving some bronchodilator. So the patient, after receiving the bronchodilator, albuterol, for example, you're going to do the assessment again. So in the albuterol is supposed to be bronchodilator. So what is happening is that it's not enough. It was not effective. So the secretion is still there. Okay. So so when you see the review the meds, you're going to check. So this medication is for what? Oh, it's bronchodilator. Okay, so they apply the bronchodilator. Yes. So let's see what is the result, the effectiveness of that medication. And then actually, if you find your secretions there, again, your nursing diagnosis according to that is going to be an effective clearing airway. So what you need to do. So that is going to report to the doctor. The doctor is going to, you need to review your physician's orders just to be sure that what is the next step, or to wait until the next time that they need to have the drug, or call the doctor, or for example aspiration, okay, aspiration of the secretions, okay, change the medication. So that there is many things that they can be done after you do your diagnosis. All right, so we have setting priorities. Setting priorities, the Maslow hierarchy, right? Maslow hierarchy. In Maslow hierarchy, so you see two patients are one side to another side, and you need to know which patient you need to prioritize first, right? So who is first? Number one is going to be ABCs, patients who have problems with ABCs. For example, A. What is A? Is the airway, right? Airway. Blockage of airway, obstruction of the airway. B is the breathing, okay? Patterns of breathing, okay? Patterns of breathing. Circulation could be lost blood, okay? Circulation can lead into, for example, if we, some changes of color in the skin because the gas exchange can be compromised if there is loss of blood, for example. You don't have enough blood to gas exchange, right? And the next one is we have ABC. This is number one, number two, number one, all of them ABC. Then we have LOC. So after you check your ABC, you need to check your LOC. LOC is level of consciousness, alteration of level of consciousness, right? The patient is responding, is oriented in space, time, and person. If not, you need to report that, and you need to know what is the cause of that. Could be, for example, medications post-op, for example, or for example, the patient didn't have that before and they start to have LOC. And altogether, ABC and LOC is you're going to have setting the patient for safety. Okay, so safety. Safety is number one in NCLEX, in your clinical practice, in your classroom, in the test and quiz, exams, etc. Safety first. Okay, so after that, you will see patients who has some problem with infection. So between patients who has infection, respiratory infection, gastrointestinal infection, whatever infection, they're they are going to you're going to see first for ABC and LOC infection. So it's important to know at this level in order to accumulate to bring data, and you need some objective data. You are going to look for the labs, heart, lungs, and ABGs. ABGs is arterial blood gases, where you are going to read the pH of the blood, 735 to 745, and there's some metabolic or respiratory variations, alkalosis or acidosis, right? That can give you another objective data in order to reinforce your interventions. Okay, so very common patients, post-op, asthma and neutropenia. What is post-op? Post-op is you need to be very careful with post-op patients. They can decompensate very easy, very fast. Any problem can be potentiated by in these patients. For example, somebody forgot the Foley catheter. Okay, or the patient is after post-op, they can pee, right? So they can produce distension of the urinary bladder, and it's very common. And yes, you cannot imagine. It's common happen, and the bladder can blow up literally, can rupture and produce some sepsis. We produce sepsis. Asthma patients, about 1% of the patient can die from asthma. Attacks, crisis, but asthma is in general. So I don't talk about asthma specifically. What I want to talk is about patient who has respiratory problems, asthma, bronchiectasia, COPD, whatever. Then the neutropenia. No, then so all these three together. So you have, for example, this post-op asthma neutropenia. Neutropenia, what means neutropenia? Low levels of white cells. So what is your risk here? Your risk is going to be for infection, risk for infection, right? So if you have a post-op asthma, neutropenic, so risk for infection, what if you have these three patients at the same time? Which one you are going to check first? So then you're going to combine your post-op ABC LOC, your asthma ABC LOC, your neutropenia or risk for infection ABC LOC. So that's how you're going to prioritize your patients. Okay, so post-op, respiratory, and risk for infections. Those are actually priorities before you to do some patient who has, for example, pain, right? Pain is sometimes very dramatic sometimes, but you need to follow the Maslow hierarchy, right? It's very hard to say, but sometimes pain is not going to, let's see this way, uh, kill the patient or kill the patient. For example, if you're going to treat a patient who has a pain for whatever reason, and you don't do the patient who has, for example, post-op, they have some airway obstruction, all right, so you have your answer, right? So you need to prioritize. Pain is very important, it's very important, but definitely there is other priorities before that. All right, so we have patient education number three. Oh, number three, oh, is the last one, but not the less important. Okay, patient education. So all what you was working from level 1, level 2, and the patient education fail, the rest is not going to work, or is going to be just go back to ground zero again. Because the patient education is extremely important, extremely important. Why? Because the patient, you will see what are the most common nursing diagnosis in what in pharmacology, nursing process applied to pharmacology. Okay, so we will see that in a few moments. All right, so among the most common nursing diagnostic levels related to pharmacology or drug therapy is number one, knowledge deficit. Knowledge deficit. Knowledge deficit. So knowledge deficit is how to take the medication, when to take the medication. Knowledge deficit, for example, is the insulin, is oral anti-diabetic medication, the nebulizers, or etc. Right? So we have knowledge deficit. So tell me one thing: if you know, if somebody's telling you how important is this, how much benefit you're going to obtain to this medication, the medication is not going to be right away having effect. It's going to take a while, but at the end you will have return to your physical activity as before, etc. Right? So if you talk like this to the patient and explaining all the side effects, for example, side effects. If you don't explain side effects, the patient is going to be, oh my God, this is not bad. This is no good, right? So I'm not going to take it. Knowledge deficit. So knowledge is actually a very important component of your interventions. We have no compliance, so those patients who want to do whatever he want or whatever they want. I take in the pill, I feel better, I keep the pill for later, or I take the pill, oh, I forgot today, or I don't care, or whatever, right? So no compliance. So the patient, in this case, you need to do, it's part of the nurse patient education. No compliance, right? No compliance. So you need to just educate the patient and give the benefits of the treatment in order to comply. And so we have three of them. So don't forget about that. Knowledge deficit, no compliance. So this is always the most common. And the other one is the risk or adverse effects. All right, so here is what we are going to stop a little bit, and we are going to just make some important remarks that I want just you to go over. Okay, so knowledge deficit. For example, the patient have new drugs. So what is that? So I really don't know why they changed my medication. So probably you need to explain that very well, right? And a related prescribed to diet, so new diet. So the patient hypertensive, for example, the patient is not in the medical field, so they don't know that the sodium retain water. They don't know if you retain water, you increase your volume, increasing your cardiac output, increasing the blood pressure. So they don't know that. So if you prescribe a diet low in sodium, so that the food is not tasty at all. So what you need to do is to explain, right, the patient what is the purpose of that. And there is some supplements of, sorry, uh, some uh, um, substitutes of salt substitutes, for example, right? Salt substitutes. What is salt substitutes? Is mostly potassium. They don't have the same taste as the salt, but they're very similar. Related to self-management of her diagnosis, hypertension, heart failure, and diabetes mellitus. So one thing, diabetes mellitus. You know what? I go into a party. I'm going to take my pill, and then I'm going to eat everything I want. No, that is totally wrong, right? Totally wrong. Heart failure, HF, is diet, especially is medications on time and restriction of sodium, right? And hypertension, we already talked about. So let's keep going. Adherence or no compliance, degree which the patient likely to follow teaching relates to how much value the patient attaches to it. So here we have the case management adherence guidelines, version 1 CMAG1, that is a manual where you have some interventions that you can use for adherence to improve the adherence of the patient. Adherence of the patient means the follow orders, follow the prescription. No compliance is actually this. It's something that is concerning us too, because the patient do not follow orders, do not follow the prescription. So for that, you need to have patient education. All right, so here we have critical thinking, and critical thinking is mostly just to make a symbol, because to talk about critical thinking, we can take about a couple hours in order to start explaining and have you an idea of what is that. But in general, critical thinking we can summarize like is how, where, when, why, comparison, differentiation, similarities, so in between drugs, right? So that is about critical thinking, and all the nursing process phases are going to have that process. All right, so we have again deficiency of knowledge and no compliance. So, all right, so that is veracity is defined as the duty to tell the truth. Okay, all right. Nursing diagnosis and pharmacology, adverse effects, interaction. So stop the video and tell me what are the three more common side effects. Nursing diagnosis. Number one, knowledge, right? Knowledge, deficit of knowledge. The other one is no compliance or no adherence. That is a diagnosis, no adherence, period. No compliance, period. That's it. And the other one, knowledge deficit. Okay, so, and the other one is the adverse effects. Adverse effect. And we are going to see how we are going to translate the adverse effects of the or side effect, if you want, for the medication into nursing diagnosis. And that is about this. So, for example, if you have some medication who is going to have the side effect, and you can see the side effect, you can verify that it's having the side effect. This side effect, how we are going to transform into nursing diagnosis. So it looks difficult, but is not that much. Okay. All right. A patient will take medication as prescribed and not changing or discontinuation it without contacting the care provider. So adherence. When the patient spontaneously start asking questions, that is the best time where you can approach the patient for patient education. So when I'm going to approach my patient for patient education, when the patient starts to say, nurse, where is my pill, or what the doctor said, or at what time the doctor is coming, or when I'm going to take my pill, etc. So that means that patient start to show interest, and that is the moment that you can approach the patient and start to do some patient education. Okay, so nursing diagnosis for drug administration, risk for injury. For example, this is the nursing diagnosis, the general ones, right? For example, risk, and we are going to go back and forward, back and forward. So these diagnoses that I'm going to show you are diagnoses that you can see in your book on your table of the nursing diagnosis. Nursing diagnosis. So risk for injury, for example. And we will see some of them, not all of them, because there's multiple of them. But I make a selection of what are actually the most common. Risk for injury that is related to risk for falls. For example, injury. What medication can be related to risk for injury? For example, you have antihistaminics. Everybody took antihistaminics, and how you feel? You feel drowsy. You feel sleepiness, right? So if you are going to go and drive a car, okay, so that is a risk for injury, right? Or if you have some machinery to manipulate, that is risk for injury too. Risk for falls is a risk for injury too, but actually you need to be related to what? For example, you have antihypertensive, okay, or you have some hypnotics like phenobarbital or some sedative in high doses that can be hypnotics are the diazepam or the diazepam or Valium, right? That is the commercial name. So if you feel drowsy and you in your bed and you want to go to the bathroom and then you have a risk for falls, right? Because you're drowsy, you're kind of LOC, alteration of LOC, so you need to be careful on that. And your interventions according to that, okay? So indirect light, companion, or the bed very low, the rails up, for example. So all these things are going to be part of your nursing intervention. Another way to describe this untoward effect that is not that common, but is what it means no favorable effects of the medication, like side effects. Drug idiosyncrasy, so mostly you don't see that in the nursing diagnosis unless it's happening, because drug idiosyncrasy is very, very rare. For example, I will tell you aspirin. I'm going to repeat that example. Aspirin side effects, gastritis. Aspirin adverse reactions, bleeding. Idiosyncrasy of aspirin, again, aspirin is going to be asthma. Okay, bronchoconstriction and asthma. So it's very uncommon to have asthma from aspirin, but happen. That is drug intoxication. Okay. All right, so let's keep going. So acute chronic pain, acute chronic pain. For example, a patient who I put cough there just to remind me the example. You have, for example, chest pain. It could be for angina, for myocardial infarction, right? So that is the nursing diagnosis. And some acute or chronic pain related to drugs. For example, you are taking some antitussive, so it's something to bring down or resolve the coughing when you have some pneumonia or infection or respiratory tract. So the patient is coughing all day, right, and non-stop. So coughing, because you have a lot of secretions. So what happened? This medication is not effective. Why? Because you need to review your plans, your goals, yeah, right, your medication itself, and your diagnosis is going to be acute pain, for example, acute pain related to the increase of secretions, okay, as evidenced by, for example, the wheezing and coughing and appearance of mucus in the pathway. Acute chronic pain. Okay, so acute, remember, less than 3 months, chronic, more than 3 months pain. Okay, so that is how you categorize pain, acute or chronic. Ineffective airway clearance, for example, again, you will see that this is made because the patient cannot have a lot of secretions, right? Airway clearance, ineffective airway clearance. And that's because, for example, for albuterol is not being used in the right dose, for example, or probably he needs an extra dose, or maybe we need to change the medication, right? Anxiety. Anxiety is one of the very common, este moment. Okay, so we have anxiety is the, how you know the patient is anxious. The patient is anxious because they is telling you they are concerned about something, right? So the feelings of anxiety are going to be, for example, a patient cannot sleep because they have too much cortisol, stress, right? Stress. Listen, stress, mild stress. Everybody have mild stress. You go to your work in the morning. You need to drive, so that is stress. That is stress. But if the stress is too high, you can enter into anxiety. Anxiety means that is not a concern. Okay, I need to fill the gas on my car, but I need to be a little bit early, and then I'm going to fill it up. That's okay. So that is a stress. But anxiety is, for example, you find out that there's some traffic accident, and you don't know what was going on. So are you going to get late? So what is going to happen? They're going to write me up, or they are going to fire me, or something, right? Anxiety. And fear. Fear is, I would say, is more severe than anxiety. Fear, as I mentioned before, is, for example, is those emotions. This is an emotion that make you feel when you have your life in risk. For example, fear is when they put you a knife in your neck, for example, that is fear, right? It's not, you don't feel, oh, I feel anxious because I have a knife. No, what you have is afraid, you're fear, right? So it's more intense fear, emotions in cases of fear. For example, in patients, it's going to be just before the surgery, right? Very critical surgery that is going to be different between life and death, right? So the patient is going to be free, having fear, right? Okay, so anxiety. So that is the, let's put it this way, the middle point on that. So new diet, for example, anxiety. I don't know how I'm going to eat it. So I don't know how to cook this. A new drug. So why is this drug? So I never use this drug. Why they're changing me? Why is new procedure, for example? Okay, senor, Mister, we are going to just ask for new labs, or we are going to ask for a new CT scan or MRI to know what is happening. So what are you thinking about, right? Immediately you say, oh my God, they are going to find something really bad on my body. So anxious, anxiety, right? All right, so in this case, anxiety, how you can resolve for in the as interventions is just explain the patient, right? This procedure is going to be like this, it's going to last like that, there is no pain, there is going to be easier, the doctor is very knowledgeable, the doctor or whatever, right? So they are going to, and you're going to come back to your place and the results are going to be coming very soon. So there is nothing to worry about, you're in good hands. So anxiety, what happened with anxiety is gone. Or at least is going to be minimized. Risk for bleeding. So anxiety, drug medication is new drugs, for example, right? I want to focus in pharmacology. Risk for bleeding. What medication can produce risk of bleeding? Okay, very good. So we have heparin. We have warfarin, right? We have warfarin is PO, right? There is no IV warfarin. And excess of this warfarin can produce risk of bleeding, right? As evidenced by what? By bruises, for example, right? Another thing where you are going to check bleeding, the gums, right, between the teeth. They're going to have some, they start to have bleeding. So what are your interaction or your interventions here? So you don't want to brush your teeth very heavily, right? So probably you need to rinse them out. You need to do, but not brush it very hard because they can produce more bleeding. And if an effective breathing pattern are going to be, for example, in patients who have some infections of the respiratory system, right? So how you're going to check? You're going to see the ventilation. Ventilation. What is the ventilation? Ventilation is the movement of the thorax when you are breathing in, breathing out, ineffective breathing. So who has problems with breathing pattern? For example, we have asthmatic patients, right? Asthmatic patients are going to have some characteristically some type of breathing they cannot be in supine position in flat in bed. They need to sit up or they need to support his arms in something solid in order to give more support to the diaphragm in order to breathe better. And for example, patients who has diabetes ketoacidosis, the DKA, they can have, for example, some acidosis, and this acidosis can correspond to some patterns of breathing, abnormal patterns of breathing. It could be, for example, chain stalk, okay, or you can have another situation, Kussmaul, be taught. So there's different patterns of, and ventilation. Ventilation is how you observe the thorax moving. Okay, that's decreased cardiac output. Decreased cardiac output. In cardiac output, you must need to remember that cardiac output is equal to say, what volume is the cardiac, listen to the name, cardiac, heart, output. So something that's coming out from the heart. What is that? Blood. So when it's coming out? In the ejection. So in every beat, the heart is going to pump out some blood. This blood multiplied by the heart rate. So the heart rate is going to give you the cardiac output. So, and cardiac output is important because if you have low cardiac output, what happens with your blood pressure is down. When you have high cardiac output, probably your heart pressure is going up. So cardiac output is related to the volume and the heart rate. If you have your heart rate low, and you have your volume of the blood low, your cardiac output is low. So as a consequence, the blood pressure is going low too. Constipation. Okay, so who decrease cardiac output? Who decrease cardiac output? Especially you will see in heart failure patients who, for example, they are going to have other patients who are bleeding. Bleeding. You don't necessarily need to see the bleeding going out of the body. The bleeding can be internal, especially in the abdomen. So there is less volume, less cardiac output, less blood pressure. Blood pressure. So that is about the cardiac output, decrease of cardiac output. So as you know, if you have less cardiac output, less blood pressure, less perfusion, the organs are not going to receive blood supply enough. Constipation, who give you, cardiac output, for example, we have excess of diuretics, okay, or excess of bleeding, or for example, caused by another medication. Or, for example, the related to medication or excess of medication. For example, we have antiarrhythmics. Antiarrhythmics are going to decrease the heart rate, and that can produce decrease of cardiac output. Constipation. Constipation. We have, for example, who can give constipation is constipation is going to be, for example, opium, morphine, morphine. Morphine is one of the side effects of morphine is the constipation. So patients who are in hospice, patients who are in end stage of cancer, they are going to have morphine. And morphine, one of the side effects, the first side effect that we need to observe is the respiratory depression, right? Second, respiratory depression, as I said in class, 5 times respiratory depression is what is priority, and then you're going to check to constipation, okay? But constipation. Of course, if you see a patient with morphine, so what is your priority? The constipation or the airways, right? So you need to check the respiratory rate first, right? So if there is less than 12, you need to probably observe them, stop the medication or the dose and report to the doctor immediately. Constipation. So you already know this side effect is being happening because of opium, and you need to be ahead of time of the situation. So the patient is taking this, so what you're going to do? So your interventions are going to be the increased water intake, one, increase the fiber content of the food, right? Some small walking, if that is possible. Assessment of the motility of the intestine, if there is a, if there is some bowel movements. So you go the stethoscope and you need to check at least 1 minute every quadrant, and you need to have about 2 to 3 sounds of the motility of the GI tract. So if that is not happening, what is in 2-3 days, this patient can have impactation of fecal material. So you're ahead of time, right? Right. So what we do is the diet, water, fibers, and the next step will be, for example, stool softeners. Stool softeners. Try to avoid enemas. Enemas are having some problems. So yes, uh, but if you follow all your nursing process, you actually with water and fiber, most of the time you're going to the patient is going to be more than deficient knowledge. So that is something that is already we've been talking is common. Diarrhea. So what can cause diarrhea? Diarrhea can be caused by many things. First of all, I want just to tell you the most common side effects of medications are the three bigs, B, IG, right? Bigs, three bigs. One is nauseous, diarrhea, and the other vomiting. Okay, so those are the three bigs. All right, so electrolyte imbalance, who can produce which, or diarrhea, for example, just finish that. If your patient is 2 days already in the hospital receiving antibiotics, the patient is going to, if the patient is having diarrhea, probably, and depends of the dose and the type of antibiotic, but mostly all antibiotics can produce the same effect, is to sweep out flora, all the flora, intestinal flora. So in this flora, the only one who can survive is a guy called C. diff, Clostridium difficile. That how this guy survive at the difference of the pre or the other ones. Remember that in the flora we have 400 different types of bacteria. These 400, including the Clostridium difficile, 15% of population have normally Clostridium difficile in their intestines. Okay, all right. So these 400 different types, they are competing for areas, right? Right. So they are going to control areas of nutrition. They are going to eat what? Fiber that is coming from the diet, right? Fiber, cellulose in salads. They are waiting for the salad that you eat, right? So you obtain the vitamins, and the remnants are going to be eaten by the flora in the intestine. So they are competing for areas, for space, right? So they are going to control the reproduction of each other. So, okay, don't reproduce too much. So wait, so we need to reproduce here. So actually they are controlling in order to survive, right? So antibiotic is coming, antibiotic is killing everybody. And the Clostridium difficile is the only one who can survive. Why? Because they will produce the sporulation. Sporulation. What is sporulation? So if somebody is giving you, for example, throwing to the people hot water. So in order to, and you cannot stop that. So the hot water is coming. So what you're going to do is, for example, cover yourself with something, right? In order to prevent the contact with the hot water. So that is what is doing this Clostridium difficile, cover against the antibiotic. But the rest of the bacteria cannot do that. So they will die. Clostridium difficile is going to survive. And then when he's alone, nobody's controlling him. So he starts to reproduce. And this one bacteria that is being reproducing can produce inflammatory process in the intestinal diarrhea. Okay? Electrolyte imbalance, just to not make it longer, electrolyte imbalance, for example, diuretics. Diuretics is when you use for hypertension, for example, right? So you pee more. But when you pee more, it's because you are not absorbing sodium. You are eliminating the sodium. You are eliminating the sodium. At the same time, you are eliminating the potassium. So you can enter into hyponatremia and hypokalemia. Hypokalemia, electrolyte imbalance, caused by diuretics. There is different type of diuretics. We are going to talk that on the time is needed. All right, so risk for falls. Patients who have hypertension, if you give some antihypertensive, the blood pressure go down. So the patient, when they start to move and try to go to the bathroom, they can fall because what we call that orthostatic hypotension, orthostatic hypotension, risk for falls. We have hyperthermia. Hyperthermia is high temperature. It could be, for example, for fever, right? Hyperthermia. And so, listen, NANDA diagnosis, fever. It's not fever, it's hyperthermia. So high levels of temperature, right? Hyperthermia is not, it can caused by infections, right? It can be, for example, after post-op, when they receive anesthetics, they can have hyperthermia, what we call malignant hyperthermia. They can lead into what? Into seizures and common death. Risk for injuries, we already talked. Disturbed sleep patterns, for example, if you have pain. So pain could be insomnia. Remember, when you have insomnia, you don't call disturbed sleep pattern for one, you don't call that insomnia. So what I'm trying to say is this. Insomnia is a diagnosis, actually. And insomnia is Insomnia is you make a diagnosis when you have 4 weeks in a row lack of sleep. So that doesn't mean that you don't sleep for weeks. It's like you have the process 1 or 2 days every week for 4 consecutive weeks. That is insomnia. So disturbed sleep pattern in this case related for example, patient with pain. The patient is having pain, and the patient, can you sleep when you have pain? No, right? So we need to just assess the patient and see what is the physician's orders in order to calm the pain. Otherwise, you need to contact the doctor. There is no orders for this and that. The patient is complaining about pain, for example, right? Okay, risk for impaired liver function. So if you remember, please remember the hepatotoxicity. So many many drugs are going to pass through the liver. Remember the first pass effect that are going to pass to the liver. So some medications are going to be very hepatotoxic. So hepatotoxic, so risk for impaired liver function. If the patient is having hepatitis, for example, it's already have some problem with functions of the liver, and they are going to use some benzos. The benzos are going to make work the liver even harder. So you need to be careful on that risk for impair of function, liver functions. Okay, nausea, vomiting, diarrhea, we already talked about that. Risk for infection, risk for impaired oral mucus. That is that is need to be, for example, there is some drugs, I mean, especially the malnourished patient who have low levels of vitamins, they can have, or they have some viral infection, or they can have a risk for impaired oral mucosa lesions. So that could be, can make them difficult to swallow the medication. Risk for infection, risk for deficit fluid volume, patient who are dehydrated, so patient who has diuretics, for example. All right, so that is what you already know in your other courses, med-surg and other courses of nursing. But today we are going to talk pharmacology, and I've been doing that because, for example, remember there's 3 things, and that is the main thing of all today. Is number 1, diagnosis for deficit of, diagnosis for related to pharmacology. Number 1, knowledge deficit. Knowledge deficit. Okay, so you already patient education. Number 2 is going to be the no compliance or no adherence of the patient, right? So another thing, patient education. And the third one is going to be based on the side effects. Side effects, for example, there is some side effects that are going to be similar as the diagnosis, going back of the diagnosis of the NANDA, right? For example, we are going to have, here we have pain, for example, okay? Pain. Could be muscle pain, could be articular pain, so that is already the diagnosis. You just need to do the, if this is acute or chronic. Anxiety, another thing that is just coming with with new medication, for example, right? For example, if you have some medications can produce constipation, so you go straight and say constipation. That is NANDA, constipation, period, right? Diarrhea, another is actually part of your assessment. You are going to see diarrhea. That is already your nursing diagnosis. Okay, electrolyte imbalance. Electrolyte imbalance, you need to make assessment of the medications that, for example, produce loss of sodium and potassium, like diuretics. That is electrolyte imbalance. But you need to have evidence of the electrolyte imbalance, like, for example, levels of sodium and potassium, lab tests, and signs and symptoms that you will learn in your med-surg. Okay, so let's keep going here. We have nausea, another straight diagnosis, similar to the side effect of the medication. Risk for impaired liver function, that is what we call hepatotoxicity, right? Here we have All right, so here we are going to start talking about the side effect. So remember, so diagnosis for pharmacology, number one, knowledge deficit. Number two is the other one is the no adherence, right? No compliance. And the third one is related to the side effects. So the side effects, what how you're going to check. Number one, for example, we have first of all, you need to know what is a granulocytosis. A granulocytosis is a deficit of white cells. One of the components of the, one of the type of white cells are going to be low. White cells, for example, a granulocytosis is probably mostly related to the deficit of neutrophils. That you can say neutropenia, but neutropenia in this case is very narrow. It's just neutrophils. But you're talking about a granulocytosis. So that means that all the cells who have granules inside, like neutrophil, basophils, eosinophils, those are actually a granulocytosis. So in conclusion, you have a granulocytosis are going to be white cells low. Okay, so first of all, you need to know this, the side effects. Which medication is doing this side effect? For example, we are talking about chemotherapy, patients with cancer, chemotherapy. So you already know, you are not waiting until granulocytosis happens. You know already that the patient with chemotherapy, they are going to depress the immune system, especially the production of white cells, right? White cells, of white cells. So if you have, okay, so what you're taking, chemotherapy, okay. All right, so what you need to think is about side effects. Step number two, side effect, a granulocytosis. What is your step number three? Is to make the diagnosis. The diagnosis is what? Risk for infections. Risk for infections. Bruises, for example, you know the medication, warfarin. The warfarin is patient who is having a stroke or who had a stroke and is having a warfarin to control, to prevent a new formation of clots, right? So you know your medication, number one. You know, number two, your side effects, the bruises. Okay, so it can be bleeding, and that is related to bruises. So if you are bleeding, if you have excess of warfarin, if you have excess of warfarin, you're going to start having bruises, appear some ecchymosis on the skin, right? And what is your the diagnosis here? Risk for bleeding. Risk for, you review your NANDA, risk for bleeding. So there you are. You have the medication, warfarin. You know the side effects, actually bleeding, right? So what is the evidence? Bruises is the side effect. So what is your nursing diagnosis? Risk for bleeding. Constipation, see, constipation is a NANDA diagnosis, but you can find this in the assessment. Okay, constipation, again, what can produce constipation? For example, morphine, patients with terminal diseases. Okay, constipation. So you have morphine. What is one of the side effects? So constipation, right? So what is your nursing consideration? So now knowing what is the sign and symptom of the patient, you coincidentally here, if the constipation is in NANDA included as constipation, so it's easy. Diarrhea again when you sweep out all the flora, etc. So you are going to have, for example, patients coming with antibiotics, right, in the hospital. The patient doesn't have diarrhea yet, but you need to always be alert on that because sometimes happens, sometimes do not. Even this, what I explained about the Clostridium difficile can happen in 2 days or it can happen after 1 year, after the patient is out of the hospital after 1 week. All right, so it's kind of a variable. So diarrhea can be, for example, it's a nursing diagnosis already. And diarrhea is actually, you can tell your intervention. What could be the interventions if you have Clostridium difficile? Safety precautions, okay? Safety precautions. I will tell you ahead of time now, Clostridium difficile, always wash your hands with soap. is not sanitizer. Sanitizer, the Clostridium difficile is going to just make a party on that. So please, just soap and water. Drowsiness. So, all right, so I'm going to take hypnotics to make me sleep. Or I'm going to use anxiolytic, benzodiazepine, because I'm anxious. I'm going to calm down. So that is all those guys are depressors, right? I'm going to take antihistaminic. For example, these medications over the counter that make you sleep. What are those? Mostly they are antihistaminics. Okay, so you are taking antihistaminic before go to work? No, of course not. So at night, right? When you want to catch up or sleep, make it easier to sleep. All right, so drowsiness, for example, you already know antihistaminics, for example. So drowsiness. And so the patient, you need to know your medication, number one. Number two, you need to know your what? Your side effect, drowsiness. What is your nursing diagnosis? It's going to be risk for falls, risk for injuries, right? You cannot put risk for sleep, right? It's not. So the consequence to be sleepy during your driving is a car accident, right? So risk for injury, or risk for falls, right? GI upset. So you, first of all, what you need to do, you need to know your medication. What medication it is? For example, let's make it some medication that produce gastritis. Okay. This gastritis, gastritis with gastritis. So please, I want just, you're going to see this in MedSearch. But gastritis, what is inflammation of the membrane of the wall of the intestine. This inflammation can stimulate the nervous system that is innervating the stomach and produce nausea and vomiting. So GI upset. So what is GI upset? Nausea, vomiting, gastritis, reflux, cramps, bloating. Okay, so GI upset. So who produce that, for example, is going to be some antibiotics like erythromycin, that is, or another, they can, or antitubercular for medication taken for months, they can produce the GI upset. So, for example, aspirin. Let's go to the simple one again. Simple. Aspirin. Aspirin can produce GI upset because they can lead into gastric irritation. Gastric irritation. And we need to live with this. Gastric irritation and gastritis. Gastric irritation mostly we use in medicine like you start to have a problem. And you already have the problem when you have the gastritis, right? So that is something that is very close, and this is the way that we talk in the medical field. Anyhow, so you have the aspirin. The aspirin is going to produce a GI upset. GI upset. So what is your nursing diagnosis here? Aspirin can produce gastritis. Gastritis can produce erosion of the mucus of the wall of the stomach, can produce bleeding, right? So what is your nursing diagnosis? Risk for bleeding. Risk for bleeding, okay? So that is how you're going to do it. So number one, your drug. What is the name of the drug? What is the side effect of the drug? What is the side effect as a consequence, what can produce? And then you're going to translate into your nursing diagnosis. All right, so let's keep going. Hepatotoxicity. Hepatotoxicity, let's go back here. We have risk for impaired liver function. Risk for impaired liver function. So that is a side effect, hepatotoxicity. Hepatotoxicity. How do you know it's hepatotoxicity? See, if the liver only complains when you have, or signs and symptoms, when you have destroyed 80% of the liver. So how in the world you're going to check if there is hepatotoxicity? Simple, right? Very good. The LFTs, liver function tests, the transaminase, the AST and the ALT, the phosphatase alkaline, bilirubin, right? All these guys are going to be the indicator that there is some damage on the liver. I will tell you something. These enzymes are inside the cells of the liver, what we call hepatocytes. Hepatocytes means cells of the liver. When the liver is being damaged, the cells are going to die. And when they die, the cells are going to release the enzymes that are inside the cell are going to go into the bloodstream. And that's how we detect. If these enzymes are elevated, that is indicating that the cells are being destroyed. So that's why you have hepatotoxicity. And that is a risk for impaired liver function. And who are these guys? For example, some antibiotics. You need to know which antibiotics are those. This is not the time, but I'm going to mention is that gentamicin, for example. Another one is the vancomycin. Vancomycin, that can be hepatotoxic. Another one, antifungals, can be antivirals for viruses. So they can actually lead into that. Headache is a general general symptom. And headache, what is headache? Pain, right? Pain. So the patient is going to have acute pain, right? Right, acute pain. So you can have related to, for example, a drug therapy or related to the some, for example, trauma, etc. Electrolyte imbalance. That is, if you see here, electrolyte imbalance is a side effect, right? But in NANDA, we saw electrolyte imbalance. So there you are, your diagnosis. So you need just to just translate it, and the translation is equal. In this case, muscle ache. Muscle ache, you're going to have, for example, where? When you have high levels of cholesterol, you're taking a medication called niacin, that is the vitamin B3. This vitamin B3 has the function to decrease the cholesterol levels in blood. But in addition to that, they have another side effect, that is muscle ache. This is, we are going to see that another time. Muscle ache. So acute pain, muscle ache related to the side effect of the niacin, right? Okay, so nauseous and vomiting, orthostatic hypotension. So orthostatic is another diagnosis. So you can say here, instead to say decreased cardiac output, you're going to mostly related to what? To risk for falls, risk for injuries, risk for falls or injuries. I prefer to use risk for falls. Orthostatic hypotension, because what is the number one, you need to know your medication, number one. Number two, what is the side effect of the medication, right? So orthostatic, now try to translate that into NANDA. As a consequence of orthostatic hypotension, the patient can fall, risk for fall, okay? And what are your interventions? Interventions are going to make the patient sitting up or getting out of the bed slowly, right? You can do some pumping of the lower extremities to bring blood into the IVC, right? All right, pain. So side effects, so we already talked about muscle pain, for example, right? Photosensitivity, photosensitivity and rash, okay? So in this case, where we are going to find is, for example, risk for impaired skin integrity. It can be there, risk for impaired skin integrity or skin integrity. You're going to see photosensitivity. Photosensitivity is a rash, actually, when you are being exposed to the light. If you keep exposing to the light, what can happen? The integrity of the skin is going to be impaired. It's going to be an ulcer, or it's going to be a discontinuation of the skin, so that can get infected. So what is your nursing consideration here? First of all, not be exposed to the sun, right? The second, if you're going to be exposed to the sun, go to certain time of the day. From between 10 to 2 o'clock is the highest UV in the environment, so better not to go. Another nursing consideration here is to use sunscreen, right? 30 minutes before you go somewhere. Okay, so first of all, you need to know your medication. What medication? For example, antibiotic. There's many that can produce photosensitivity, especially the creams and ointments that are being used for virus and for fungus. those can produce photosensitivity. Another can be, for example, just to give you examples, antibiotics. Antibiotics, for example, we have tetracycline, we have macrolides, we have sulfas. So they can lead into photosensitivity. Okay, so know your medication. What is the side effects? And what is your nursing diagnosis, right? All right. Tremor, xerostomia. Xerostomia is what? Tremors is involuntary movements. And tremors are going to make you lose coordination. Tremors is going to be happening in medications, for example, when any medications that can produce some tremors, for example, MAO inhibitors, no, the chlorpropamide, for example. Chlorpropamide is a prokinetic that make the stomach evacuate faster. And that is going to be using for some signs and symptoms like nausea and vomiting. Anyhow, so this medication, when you give, they can produce tremors. In this case, it's not that common, but these tremors can produce instability and risk for falls. Xerostomia. Xerostomia is the dryness of the mouth. Okay, so what medication can produce that? Dryness of the mouth are going to be, for example, the anticholinergics. Anticholinergics is going to prevent contraction, right? So, for example, we use when you have urinary incontinence or hyperactive urinary bladder, they give you anticholinergics. This or for example, if you have some spasm, or for example, you have a stone in the ureter or a stone in the gallbladder, they can give you anticholinergic. Or for example, you have asthma and they have too much secretion, they give you a little bit of ipratropium that is anticholinergic to dry. So in this case, the side effect, systemic side effect, is going to be the what? Dry mouth. So, and why we don't want dry mouth? Okay, dry mouth. So what? Well, it's very important because dry mouth is going to produce erosions in the mucus, and that can lead into ulcers, some problems of pain. They cannot eat, they cannot, and produce other consequences, right? So, xerostomia. All right, so number one, you need to know your medication. What is in this case? Let's make it anticholinergic. This anticholinergic, what main side effects? So mostly are dry. So in this case, dry mouth. They're going to produce some blurry vision. Why? Because the moisture of the eyes are getting dry. When your eye get dry, you don't get blur, right? It's blurry. The same thing. Okay, so here we have xerostomia, and that is going to be what, for example, nursing diagnosis. How you can translate that? Risk for impaired oral mucosa membrane, right? So that is how we are going to deal with the medications, side effects, and the nursing diagnosis. Okay, so what is your intervention here? Intervention is just to moisture the mouth, to hit some chips, ice chips, for example, right? So xerostomia. All right, so that is about the planning. So please, I want you to remember a few things here. Number one is to know your medication very well. Number two, to know your side effect, the name of the medication. One, two, the side effects of the medication. Number three is how that side effect can be translated into the nursing process, or the nursing, or NANDA, nursing diagnosis. So as a summary here, what we are going to do is, number one, the most common nursing diagnosis is knowledge deficit. Number two, compliance. So you need to assess everything is everything. So you need to know your implementation. Third, the side effects. In the side effects, you're not going to put side effects. You don't put that. you are going to put an already translated nursing diagnosis. Okay? All right. Planning and goals, you need to planify and plan to make the goals. For example, how soon I want to make the pain go down, how soon I want to the fever go down, how soon the patient need to do bowel movement, how soon the patient is going to start solid food, right? So the patient, they need how to use the machine or nebulizer or the syringe, the insulin, etc. Right? So that is your planning and goals. So let's keep going. Implementation or interventions, right? First, administer medication, the sick rights, okay? Not more than 30 minutes from the already indicated time. If there is missed, you need to contact. If there is some administration meals, you need to contact the as soon as possible. ASAP, ASAP, no. Well, as soon as possible. The healthcare provider. Sorry for that. Autonomy includes self-determination. So the patient needs to learn. And remember that one of the components of implementation is patient education. Patient education. So in order to prevent the prevent the no adherence of the patient, right? So provide writing instructions of the patient. Okay. Implementation, including the patient education, you need to tell what signs and symptoms, what side effects are really bad that you need to really go to the doctor right away. So for example, you have pyridium for urinary tract infection. It's anesthetic. Why? Because you have dysuria. You have UTI, urinary tract infection. When you pee, you have pain. It's burning. So you're afraid to go pee. So in addition to give you the antibiotic, they are going to give you pyridium. Pyridium is anesthetic. So it's going to anesthetize the urethra so you can pee. Especially little girls are going to have this. They're very afraid to that. Okay, so, and this pyridium, what it's doing is giving you the urine become red. So if you don't explain anything to the patient is going to say, my God, I'm dying, I'm bleeding. And that is not bleeding, it's just a medication that is actually make the urine red. But it's not blood. It's not blood. So you need to educate the patient in that case, okay? So, and if there is some major side effect that they need to know, for example, bronchospasms in patients who are receiving antihypertensive medication that compromise the ABC generally and the LOC, those are things that the patient need to do right away, go to the doctor. Okay, writing instructions, you need to remember that all the instructions are going to be easy to read. You're not going to give a book to read, right? So they're very specific, going to the point, and in order to instruct effectively the patient. And all the information, the NCLEX question is going to be written in the grammar or in the way that the patient can, patient of 7th grade can understand. So everybody can do it. So 7th grade level, that is how the information is written for a patient who is 7 years old. They are going to able to understand. That is actually. So we are talking about implementation interventions. We're talking about nursing actions. So we have dependent actions, independent actions, and the other name is collaborative actions and independent actions. So dependent actions, dependent. You depend on what? Of an order. Which order? From the physician to give drugs, the medication. So drug administration. Dependent order because you depend in the prescription. Independent action, the third one, is when you nurse initiate. That is your patient education. Interdependent or collaborative action is a team cooperation. For example, the respiratory therapy, we have some, we call cardiologists or endocrinologists or neurologists or surgeon, and to see the same case, for example, laboratory, for example, etc. Right? Interdependent. All right, so negligence, open eyes, open ears, is the failure to act in a reasonable and prudent manner, or failure of the nurse to give the care that reasonably prudent, cautious nurse would render or use under similar circumstances. So actually, in other words, you make a mistake. So that can be actually negligence. They have some legal definitions that we don't want to go on here, but negligence is actually your responsibility at the end. Okay, so be careful with it. Evaluation is the monitoring the therapeutic effect. So after all this, what you're going to do? I have a patient who is, for example, let's put it this way, pain again. So you come to the patient, you have your shift, you go to the patient, and the patient is telling you, oh, I have pain. I still have pain. And you start to make your assessment. You're going to make your diagnosis, okay? Your diagnosis is going to be acute pain related to, right? Or as evidence as, right? And sometimes as evidence as is not applicable. So you just are related to. And you do your, the next step is the planning. What is the plan? For example, you need, is the pain mostly are PRN, so as needed. So the patient probably is having, they need another dose, or for example, they took a dose, it's not enough for the patient. So you need to report that. How to report? Nursing notes, and you are going to just request the doctor to, the patient is requesting pain medication, etc. Right? Okay, so then after that, your planification is telling, okay, I'm going to give PRN medication, and my goal is to reduce the pain in half an hour or 45 minutes. Okay, so that is your plan or your goal and your goal. Then you go to implementation. Implementation is the intervention is to give the pill, right? And then after that is the evaluation. Evaluation, you come back to see how the patient is doing. Okay, and you have three options, and that is important. So after all this you did, you need to have conclusions. Number one, revise the plan. Why revise the plan again? Because the patient is still in pain. So probably we need to reconsider something, or probably we are missing something, right? So we need to just reassess the patient. The other option is discontinue the plan. If you discontinue the plan, it's because the patient is actually not in pain anymore, right? And continue the plan is because probably need to certain more time in order to make effect, or the patient is getting better but probably need a little bit more time. So you need to reassess the patient again, do your nursing diagnosis, you do again your planification, the outcomes, the implementation, and go back again. So it's like a cycle again and again. All right, so lifespan, we are going to review a few things here. What I want you to remember is about pregnancy. Pregnancy, we have 3 trimesters, first, second, and third. The most risk for have some drugs or substances can pass to the fetus and produce malformation are in the first trimester. Number one, why? Because the embryo is just forming, it's more susceptible, it's changing, it's reproducing a lot of cells at the same time. So we don't want any disruption about that. And second is because at that time, the blood flow increased dramatically to the uterus. So that's why it's higher risk for some substance can pass through the placenta barrier. So during pregnancy, the one I want you to remember is we have A, B, C, D, X. In NCLEX, they are going to ask you about X. X is they can by sure produce fetal abnormalities. For example, biporic acid, lithium, excess of vitamin A. We have many of these. They can be causing fetal malformations. A, you can take it. B, you can be more careful. C, probably has adverse effects, but you need to be extra careful. And category D, extra careful. So we don't want those medications. So I will suggest take medication category A, but you need to be the pro and the cons. What is the benefit? What is the situation? And that is according to the doctor's order. Category X, never. For example, yeah, we are going to see like lithium, so that's what I just mentioned. Drug therapy during breastfeeding, so there is some medication who pass through the milk, for example, benzodiazepines. Pediatric, the most common pediatric drug calculation is milligram to kilogram, open eyes, open ear, on the body weight. To give a drug, consider the weight, age, and area of surface area. This is weight and age, the weight and age. If the patient having a certain age, the weight that is required, that means that the patient is mature, okay? All right, so just in general, when we are talking about pediatric doses and geriatric means elderly people doses, mostly we start with lower doses. 1/3 of the dose, 1/2 of the dose, and then they're going to see how the patient responds. Why? Because the pharmacokinetics and the pharmacodynamics are going to change, are going to not change, but it's going to be different in pediatric and elderly people compared to adult patients. Okay, we have pediatric dose calculation West normogram, a method to calculate dosage of medicine which can be given a child based on the dosage suggested to the adult. That is the normogram, and that's what I just mentioned. Pregnancy, we already know, increase the blood flow. So if you increase the blood flow, what pharmacokinetics is going to be changing mostly? The distribution, right? Remember the ADME, no? Absorption, distribution, metabolism, and excretion. So distribution is related to the blood. Remember, distribution is when the drug is transported through the bloodstream towards the receptors, right? Towards the receptors. All right, so here we have geriatric, we have pharmacokinetics, we have absorption, distribution, metabolism, excretion. So absorption, just to remember, go down. Distribution, go down. Metabolism, go down. Excretion, go down. So if you have absorption go down, the bioavailability are going to be lower. So how is that? You have less gastric acid production. Okay, so mostly the medications are being made in order to be dissolved in acid, in the gastric acid. So if you have low gastric acid, there is no, they are not going to break down the tablet in small components, so they cannot be absorbed. Diminish the gastric emptying, so that means that they are going to stay longer in the stomach. Okay, the motility is low. The motility is low. Diminish the blood flow, area of absorption, the V line get flat. We have distribution, the cardiac output go down. Why? Because remember, cardiac is volume by the heart rate. That is the patient is going to have about less volume of in general, because the total water in the blood is going to be 65%. Plus the heart is not pumping as before. Total body weight is going to go down. Production of proteins are going down. The proteins production is going down. Metabolism are less blood flow. They are going to have less enzymes. Okay, so decrease the metabolism. So that means decrease the metabolism. We are going to see a summary at the end. Excretion, diminish glomerular filtration. So what happened? You take a medication. First of all, the absorption is going to be diminished. Got it? Now, in the distribution, you have the less production of protein. So that means that you have more free medication. These free medication are going to be active. This is the one who is the medication is active. Okay, and that can produce an overwhelming action on the cells. So they can produce toxic levels. Metabolism the same. Metabolism is happening in the liver or any other cells on the body, and the enzymes are going down. So you decrease the metabolism. So mostly of the metabolism, what they are doing is, in the majority of the cases, are going to inactivate the medication. If you cannot inactivate the medication, you can have toxic levels. Excretion, the glomerular filtration is going down. So it's less filtration, less number of nephrons. So that means that medication stays longer in your body, especially the waste product, the metabolites, and that can produce toxic levels. So what is the conclusion about this? Is that you need to give the patient what? Start with lower dose, 1/3 of the dose, half of the dose, and then full dose if that according to the doctor's orders. Pediatrics is going to be the same. So the pharmacokinetics are different from the adult people, are going to be diminished absorption, diminished distribution, diminish the metabolism, diminish the excretion. So in elderly people, what happens is because you produce less enzymes. You have your liver start to produce less enzymes. Your heart is not working properly. You have less volume of blood, of fluids. You have less gastric acid. And all this is because there are tissue are being degenerating already. They are not working as before. And in pediatrics is similar, but the key here is that the organs are not mature enough. So they are not reaching the maximum function or the maximum product or maximum activity that they require. They are going to reach in adult. So pediatrics for immaturity organs and elderly people because they cannot produce anymore as before. Ethicals, we have, I want just to go into the change topics here. We are going to talk about cultural ethical considerations. So ethnopharmacology, so some medication, some patients are going to have some beliefs that we need to respect. For example, Indian American they believe into harmony of nature. So if somebody, probably you believe that too. Some people do it, some people don't, etc. But we need to respect all that. So we need, if the patient is telling you, you need to hear. Okay, you need to honor your position and honor the patient in order to yes, actually patient satisfaction, right? Remember your QSEN, right? Knowledge, skills, and what? Attitude. Remember that. That is the first slide. African American, when addressing elderly family members, generally prefer to have their formal name, for example, right? Hispanics, they have they use folkloric medication like herbs, for example, and they like to use some rituals like prayers or like some activities that are going to enhance the patient get better. Okay, so when the drug is need to go out in the market, we have 4 phases. All right, so first of all, just to make it simple here, we discover a new substance that can be used to cure something. Okay, so everybody's happy, and we need to put it in the market. But wait a minute, FDA said, you need to have a trial. You need to be. You need to prove us that this medication is not going to kill people. So you say that it's doing something good, but we need to have the proof. Okay, so what we are doing is, first of all, we are doing animal experiments. Unfortunately, we need to do that. Animal experiment. Animal experiment. When you finish the animal experiment, you're going to pass into the clinical phase. The clinical phase is in humans. So animal first, second humans, and this clinical phase is going to be phase 1, 2, 3, 4. You don't need to remember exactly how is these phases in detail, just general. Phase 1, volunteers to establish the pharmacokinetics. So that's how we find the pharmacokinetics. The pharmacokinetics, ADME, absorption, distribution, metabolism, and excretion. So they are going to measure the medication in the urine, in the blood, after 1 hour, 2 hours, 3 hours, what are the side effects, etc. So that's pharmacodynamics later. But pharmacokinetics is how fast is the absorption, how much is going to be distributed into the tissue. The metabolism is going to how fast is going to be metabolized, deactivated or activated, and how easy or how fast is going to be eliminated. So phase 1, volunteers, open eyes, open ears, they need to know very well what is the medication for in these trials, and second, they need to sign a consent that this patient, this person can go into the trial. Phase 2 is as previous but in large groups. Phase 3 is going to be compared with other drugs. And phase 4 is going to be in different population groups. So that is order. How long is it going to take? 10 to 15 years. So one drug to come out to the market is taking about 10, 15 years. Okay, so let's keep going. So we have placebo is very important because CAM is preventing the bias. Experimental drug need to sign a consent so that you're going to use experimental drug. Orphan drug that is developed for rare diseases, and legend is called the prescription. So we have the we was talking about pregnancy and the categories that is A, B, C, D, and the X. Those are in order to know if this medication can produce some adverse effect in the fetus, right? So now we are going to talk about the schedule. This schedule, please, open eyes, open ears. The schedule we have 1, 2, 3, 4, 5. This schedule is being, there's other classification, another classification we are going to see soon. But here schedule means that how the drug can produce dependence on the patient. So dependency. So for example, drugs like psychedelic drugs. So we have heroin, for example. Nobody treat anybody with heroin. Those are drugs that can produce high abuse potential. It's having high abuse potential. All right, so don't recognize medical. That is Schedule 1. Marijuana, please, marijuana, legalize, not legalize, is Schedule 1, period. Okay, is Schedule 1. Schedule 2 is going to see that it's less addictive. The Schedule 1 more addictive, the Schedule 2 less addictive, the Schedule 3 less addictive, 4 less, and 5 almost no addictive. The Schedule 2 is a medication. For example, we have hydromorphone or oxycodone, is the Percodan. We have codeine, that is for coughing, that is effective in October 2014. He was what? He was Schedule 3. Now it's Schedule 2. Schedule 2 hydrocodone, meperidine. So just remember the codeine. Codeine is one of the classical questions. Of course, you need to be familiar with the other names here. So what happened here is that you go to the doctor, they give you a prescription of codeine. You go to the pharmacy, they go to the codeine, they give you the codeine, and then you go back, want to have a refill, and say, no, you cannot have refills in Schedule 2 opioid, in this case codeine. Why? Because they can be, drug should be under control. So what you need to do is to go to make another appointment and go to the doctor, and they are going to give you another prescription. Okay, so they need prescription. They are not going to do refills with Schedule 2. Schedule 3, they have refills, yes, but the refills no more than 5 times in 6 months, 5, 6. Refills no more than 5 times in 6 months. For example, we have anabolic HRT, hormone replacement therapy, injections, for example, of estrogen, or could be testosterone in cases of hypogonadism, etc. Barbiturates are actually hypnotics, and they have refills, yes, but no more than 5 in 6 months. Number 4, we have diazepam. Diazepam is the benzodiazepines. So low abuse potential. They have medical use, and they can have refills according to the doctor's order. More than 5 than 6 months probably. Schedule 5, we have the dextromethorphan is OTC, all the OTC. Low abuse potential, physical, psychological. So here we have actually is what we call the OTC. Remember, schedule is based on medication who can produce addiction. The highest addiction, 1. The OTC, no addiction or very low addiction, 5. So here we have, you can stop the slide, the video, and you can check here this chart. All right, so here we have the last slide is the box warning, black box warning. So this black box warning is the classification of the drugs according to his can be dangerous for the body. For class 1 is the most dangerous, class 2 can be dangerous, and class 3 not dangerous. So that is a different classification. Remember, the schedule 1, 2, 3, 4, 5 is just to know if this medication produce addiction. This class 1, 2, and 3, a black box warning, is to tell you if in general they produce damage or good in the patient, okay, on the person. So with that, we finish the lecture today. I hope you have a better idea or clear idea, or I clarify. If not, just please let me know. I want to thank you, Alba and Consuelo, for to be joining me today. And, any questions, Alba or Consuelo? Okay, I cannot hear you very well. So please, I will suggest if you can email if you have some questions. And again, I want to thank you, all of you, to be present today in our webinar. So our next webinar is according to the calendar. So thank you so much, and I will see you next time. I will close the file today, right now. Thank you so much. Have a good night.